I will discuss about lesion preparation, and I realize that really something that it is really important, but everybody knows how to do lesion preparation. So I will prepare something a little bit different. We got the consensus of how to do a really proper lesion preparation, just to follow these steps that has been mentioned: predilatation with a POVA using a semi-compliant or non-compliant balloon preferentially. Then try to size your vessel 1-to-1 with your balloon. We try to tendons to have a long inflations, more than when we implanted a stent, 1 or 2 minutes or even more longer. And repeat inflations sometimes are required. If there's not a good predilatation, you can use a specialty balloon, for example, cutting balloons, super high pressure balloon. These technologies are really helpful to get a really nice lesion preparation. Also, IVLs is welcome, and atherectomy, rotational, orbital is also needed in some cases. Laser, just in a few cases of in-stent restenosis, I will admit. Also, we have to rely on functional measurement like wire-based or imaging-based physiology. It is getting more and more interesting every single year, and also intracoronary imaging via IBUS or OCT give us a lot of information regarding what type of tools do we need to really have a good lesion preparation before we deliver the drug. So once we have lesion preparation and we have acceptable angiographic result, meaning residual stenosis equal or less than 30%, no flow limiting dissection that we have discussed previously, and potentially an FFR greater than 0.80, then we can decide to put a DCB or not, always taking into account the AKG and the chest pain of the patient, of the status of the patient. So obviously we have to rely on what we see on angio. This is a procedure that is based on angio. So we have some criteria on angio when we are using DCB for in-stent restenosis. There are independent predictors of target lesion failure that we already know. But also we have predictors regarding more on dissection when we are treating de novo lesion with DCB, meaning the TIMI flow. We have discussed this before. We have an important parameter, which is a residual minimal lumen diameter that we obtain after lesion preparation, and also the persistence of extraluminal contrast hanging up in the angio. These are parameters that are important to take into account. But also, if we use intravascular imaging as a tool, as a friend in the cath lab to decide if we need to upgrade our predilatation, I think we get nice information. We know that intravascular imaging is a 1A indication when you're using drug-eluting stents, but also when we are using a DCB PCI guided by imaging, IBUS help us. IBUS guidance is associated with greater lower in segment late lumen loss and also smaller diameter stenosis when we compared only with angio guidance. But also, if we use OCT to guide our DCB PCI procedure, we have some predictors, like is the medial dissection. We know that these medial dissection are friendly dissection, and the dissection that we want to have in order that the outcome of the DCB PCI is better with time. And also, calcified lesions are our enemy. More calcium, no presence of medial dissection are bad prognosis in the long term for the novel lesion. But how to achieve an optimal lesion preparation? I think key points are important. It must be as throughout and as aggressive as required, as you saw in the presentation from Thomas. M to balloon to artery ratio 1-to-1. This is very important, and the predilatation should be gradually progressive impression in atmospheres, not going like crazy, really rapidly increasing the atmospheres. You have to go 2 by 2 by 2 atmospheres, incremental in balloon size also, longer than standard predilatation, repeated if necessary, and use any tool to achieve good predilatation. You can use any of these tools. We are not going to discuss all of these. You already know them, from semi-compliant, non-compliant, scoring, super high pressure to cutting, IVL, rotational, and laser. Every single device has different characteristics, and every single device is useful in the cath lab. But I think one of the concepts that is really important is that potentially this scoring or cutting balloon could help us to transmit and facilitate the uptake of the active drug in the endothelia. So this is what we are getting with predilatation with the different devices that we are using. This is an OCT in a patient where we use the NC balloon, so you can see these medial dissections in this lesion when you use an NC balloon 1-to-1 ratio, a nominal inflation pressure. This is what we want to see. And this is also something that we discussed previously. Some people will react with this, put in a stent. We need to teach them that this is what we want to see in the OCT after lesion preparation. If you're using scarring balloons, you can see these small cuts or microchannels that you will get after 1-to-1 ratio nominal inflation pressure with scarring balloons. What happened with carrying balloons? You get a little bit more deeper microchannel or cuts in the plaque. It depending if you undersize your carrying balloon 0.8 to 1, or if you go 1-to-1, you get a deeper cut. If you go 1-to-1 with a high pressure, you get a really deep cut, which potentially will facilitate get a more lumen at the end of the procedure. What happened with IBL? IBL is interesting because the channel are really avenues, not channels. They are increasing the size of the channel that you are opening. And with this last inflation that you have to give with IBL, it's acting like a non-compliant balloon. But when you combine the carrying balloon and intravascular lithotripsy, you can have a lot of dissection. You completely dissect the vessel in a way that we want. So is this really what we want to achieve before delivering the drug? I don't know. But potentially, this is really something that we need to study further. So if we want to believe that we are delivering the drug, we have to analyze what is happening before and after the drug. So this is what's happening after you deliver the drug, specifically with sirolimus-coated balloon with crystalline sirolimus. You can see the deposit of crystalline sirolimus in the endothelium after delivering the drug. You can see the particles really bright with shadowing behind. And you can see also that these particles go inside these dissections and the drug stays in that dissection. When you use a carrying balloon, an IBL, and then you put the drug, you can see the particles, bright particles in the endothelium, but also in the cuts that you induce with these devices of coating or scarring. But also these particles, this drug, get in contact with the dissection by itself, above, beyond the dissection, and is part of the process of healing of the dissection with the pass of months of follow-up. You can see clearly here how the drug interacts with the dissections. What happened with this drug? When the drug stays in the vessel wall at 1 month, like is in this patient, these particles are covered by tissue and behaves normally as a stenostrate endothelialized. So you can follow, you can track with the technology that we have, is able to even measure the size, the length, and the disposition of these particles at follow-up. This is at 1 month, and you can have it at 6 months, 4 months. You have it on the left. After DCB PCI, you can see the dissection, the particles, the shadowing behind them, and you can see at 4 months follow-up with the dissection completely healed and still seeing some particles in the endothelia. So this is important because we have talked about the distribution, the drug amount that we can deliver in the vessel wall. So we are working a lot, and was a nice couple of talks before in the morning regarding the use of imaging, intravascular imaging, or not invasive imaging. So we are working on that from both sides, using AI to analyze the amount of drug that we deliver in the vessel wall, to track that drug once it's in the endothelia up to the median wall. And then we are using also AI in the CT scan. And this is very promising, and I think it's part of the future that we want to have, potentially not to use intravascular imaging in every single case, but to use CT scan or non-invasive imaging to track and to continue assessing the patient a longer-term follow-up. So this is a case that is important to have, because we also fail when we do not really good lesion preparation. This is a focal lesion of a 70-year-old man in the proximal LAD. Seems to be a simple lesion. We tackled the lesion with semi-compliant and non-compliant balloon. This was the result. No, it was super perfect, but it was okay from our perspective, so we continue with SCB. in this case, and this was the final result after SCB, sirolimus coated balloon in this case. It was a good case, not super perfect, but it was enough for us. What happened at 2 months? The patient was admitted again with a restenosis in the lesion that we have treated 2 months ago with a sirolimus coated balloon. What happened is not a super tight stenosis. We did a functional assessment. It was positive. The patient has symptoms. So we decided to take a look what happened. And that is what happened. We didn't saw this all amount of calcium that the patient had, and we missed it in the angio. And the angio was not fairly seen, but when you do and take a look inside, you can see these not protruding nodules that you have to deal before you deliver the drug. So that is what we did. Non-compliant IBL and cutting balloon. This was the final result after lesion preparation. It was fine. We used, once again, sirolimus coated balloon because we think that the failure was the lesion preparation, not the device. This was the final result, and the patient almost 1 year after this procedure was completely asymptomatic. But I don't want to finish with a bad case. I want to finish with a good case. Lesion preparation is the key. So super complex plaque, calcified plaque, and another plaque, really simple in the left circumflex. So we tackled this first doing rotablation, I think. Yeah, this was rota all over the vessel. And then after rota, we were able to advance and to do NC balloons, cutting balloon, and shock wave in the entire vessel. Then we used the entire vessel. We painted with sirolimus coated balloon. And this was the result after lesion preparation. So it is possible. You need to use all the tools that you have in your cath lab in order to get a great lesion preparation. And the other lesion was a simple non-compliant balloon, DCB, and that's it in the same patient. So this behaved different from every single patient. So if you achieve a really good lesion preparation, you can see that the evolution over time in these patients are really benign, and the outcomes are really superb when you're using a DCB, like in this case, a 3-year follow-up after a DCB PCI in the right coronary artery. This was the OCT baseline with the particles there, with the dissection there, with acute vascular response. But at 3 years, there is a progressive endothelial healing in these cases. And this is very important, I think, for the younger patients that are arriving more and more often in our cath labs. So in conclusion, I think this is the last slide. We have a lot of things to learn still. And this is the meeting where we have to pop up questions. For example, should we recommend to use a non-compliant scoring balloon or cutting balloon as the last tool after we finish with our lesion preparation? We have to think about that. Potentially, we need to analyze the role of imaging before putting the drug in the vessel wall, using index of plaque attenuation on this new methodology of microcirculatory evaluation. We need to gather information in order to get a nice recommendation for the future use of these technologies. Potentially, we need to leave some lesion with not less than 30%, 30 to 40% in some specific anatomical or clinical scenarios. Sometimes is enough, or less is more. And of course, all the imaging tools that we are getting with more information, it is important to analyze it and to adopt it to give a good recommendation. So potentially we need to update the expert consensus recommendations in the near future. So in conclusion, proper lesion preparation is key to success, and we need to teach them in every single case. It must be as throughout and as aggressive as required. We need to have a lesion preparation that requires potentially all the tools that we have in the cath lab in order to get the most important and adequate angiographic result. And this will achieve a very good result at the outcome, long-term outcome of our patients. Thank you very much.